So Rami, you can share your screen now.
Here we go.
Can we start now, sir?
Yeah, I'm ready.
Great.
We have 2 more minutes. You are live on YouTube. So I'll leave that in your hands, Dr. Rima.
Okay.
And
should we start it now?
No,
for 1 or 2 minutes.
We have 2 more minutes, and then you can introduce, and then we will start. Okay? I'll be quiet from this point forward.
Sure, sir.
I'll be on mute. Thank you, Rami. Appreciate it, man.
Thank you, Muhammad.
I think it's time to start our session now. Rami, can you hear me?
Yes, I can.
Okay. Bismillahirrahmanirrahim. Assalamu alaikum to all the viewers and listeners. My name is Rima Sayyed, and I will be moderating our today's session on anticoagulation stewardship, a roadmap to excellence. We welcome you all from the platform of Giving Back to Pharmacy in Pakistan. It's a non-profit organization and a volunteer group which will focus on knowledge sharing of best practices in the field of pharmacy to all pharmacy colleagues in Pakistan. Now, moving on to our today's session, and our speaker is a very intelligent and hardworking pharmacist, Dr. Rami Ismail, who had worked as a clinical pharmacist at St. Francis Hospital in Indianapolis for 6 years. He had worked mainly in critical care setting and in the intensive care. Dr. Ismail is a board-certified pharmacotherapy specialist, a board-certified critical care specialist, and a certified anticoagulation care provider. He joined Cleveland Clinic Abu Dhabi in 2014 as a lead clinical staff pharmacist. Okay, listeners, we'll be running a live question answer session at the end. So if you have any queries, just type it down in YouTube's comment section, and we will be entertaining them at the end, inshallah. So over to you, Dr. Rami.
Thank you, Dr. Saeed, for the introduction. Assalamu alaikum, everybody in Pakistan and everywhere, wherever you are listening. Let me start out by just express my gratitude to the organizing committee of the Giving Back to the Practice of Pharmacy in Pakistan, the organizing committee, especially Dr. Siddiqui, who had invited me to present to you today. I have the utmost admiration for what you guys are representing and what you are advocating for. And to sit here today and pitch to you about something that's near and dear to me, that is the anticoagulation stewardship, is something that I'm honored by, and I can't be but humbled by it. So without further ado, let me just go ahead and get started. So the title over here says Giving Back to the Pharmacy of Pakistan. So as an icebreaker, what am I giving back? So I must have taken something from Pakistan throughout my life to give something back. So here it is, growing up through my childhood and throughout my studies and through work, I have worked with so many great individuals from Pakistan to whom I shared great memories and great experiences, great food as well. So it is for mainly the food that I'm sharing this back. And here it starts. We're going to talk about anticoagulation stewardship and the roadmap to excellence. So I have no financial relationship to disclose. So our objectives are to outline the core elements of an anticoagulation stewardship program, a great anticoagulation stewardship program, discuss the need and the value of implementing such a system-wide program and justify its value, discuss the key strategies to achieving and maintaining excellence, along with defining the role of pharmacy as a key pillar to the success. And let me just start out and say that I am not necessarily sharing something that we have done here today at the Cleveland Clinic, Abu Dhabi. It is something that we are now advocating for. You could be probably ahead of us leading these initiatives at your organizations. We probably could be ahead of you by a little bit. We're still probably, I would think, taking baby steps. We have a lot of elements that were put in place, but it is very nice just to put it all in one focused approach and discuss it all together. So a couple of days ago, one of my colleagues approached me about the title of the presentation, and he said, stewardship. Is there something that's called anticoagulation stewardship, or you're just making that up? So I laughed and I said, well, actually there is an actual definition for anticoagulation stewardship. It is a coordinated, efficient, and a sustainable system-level initiative that is designed to achieve optimal anticoagulant-related health outcomes and minimize any avoidable adverse drug events. So a group of individuals, expert opinions, and government and quality assurance organizations had gathered together, I believe about 4 or 5 years ago, and in an attempt to put together strategies and policies to advance the practices towards safer and more efficient anticoagulation management at different care settings. And these were through the application of optimal evidence-based care, to ensure appropriate prescribing, dispensing, and administration of all these anticoagulants and reversal agents, and work on all the provisions of appropriate patient monitoring and for optimal clinical responsiveness. These group of individuals and organizations had gathered together and had been successful and had obtained an FDA funding, through which they have put together goals, policies, and procedures, and they have leveraged the success that was seen through the antimicrobial stewardship programs and used it in order to come up with this initiative and such a program. Such a program and its core elements had led to the update or major updates in the national patient safety goals at many levels through the management of anticoagulation, through prescribing, policies and procedures, management, transition of care, reversal agents, and so on. So why is the anticoagulation stewardship a big deal? We all know that we have so many non-warfarin anticoagulants that came out in the market in the last 10 years, with every day having an expanded indication for these agents, such as for peripheral vascular disease or acute coronary syndromes, DVT prophylaxis. And these drugs are coming up with rapidly evolving evidence and updated guidelines. Not to forget also the DOACs are being among the top 10 drugs accounting for the ED visits and hospitalization, with all these adverse drug events being reported throughout different platforms that show the suboptimal quality across all care settings. Long-term patient care adherence is proven yet to be adequate. And it is also known that 1 out of 8 patients probably within 1 year will experience an interruption or a resumption for their anticoagulants for an invasive procedure. With limited reversal agents available, the need came to put together strategies and policies in order to address all these needs. So the key principles for a good and an excellent anticoagulation stewardship program is to have it as an evidence-based program that is centered around the patient. It is something that's systematic, that's going to touch all care settings, broadly defined for to capture patients in the inpatient and the outpatient settings, and it is integrated as well. So this is the summary of the core elements of the anticoagulation stewardship program. You know, I can think of these core elements as a cogwheel. They're all going to have to work together longitudinally. They're not building on each other. They're not a pyramid, but they all work together, and you cannot actually start with one without working on the other at the same time. The first core element is to secure administrative leadership commitment. Then you would need to move on and establish a professional accountability, expertise, engage your teams, perform the data collection, and work on all your metrics and analyses. Incorporate those into a systematic, on a systematic level, facilitate the transition of care, and ensure that you are advancing the education and the competency throughout all disciplines of care. So let's take them one by one. The first step is to secure the administrative leadership commitment. This is dedicating necessary human, financial, and technology resources. And here we ask ourselves, how should we advocate, how should those advocates prepare for discussions with the leadership in order to secure that kind of a commitment? I mean, this could range anywhere or take a number of forms. Endorsement within an institutional statement or strategic plan. You want to ensure that you want to secure budgeted resources, and talk about strategies and safety initiatives that you would want to push throughout the organization that will align with the patient needs currently being discussed. With that, you would need someone with someone who's a fierce advocate, someone who's a communicator, and someone who has actually have a great sphere of influence within the organization that can push something like that and justify it. You want to establish a professional accountability and expertise. And this is very important, to appoint a single leader that will be responsible for those high-end deliverables that you wanna pitch to your listening ears within your C-suite or a hospital administration. That's if we were talking about a hospital, or if we were talking about a long-term care setting or a polyclinic, and so on. The key duties for such a leader could include, but not limited to, developing stewardship goals, identify and petition for these resources, evaluate and report the program on program performance, and represent and advocate for the program at an administrative level. Moving on, now you would need to engage and incorporate all the disciplines. As we know, all these listed disciplines within a hospital or healthcare setting will be touching anticoagulation at some point. So it is a key or a recipe for success to have the input coming from all these disciplines in order to have a robust anticoagulation stewardship program that will be successful, to have that continuous feedback in order to ensure the sustainability and the success of the program. You could ask yourself, who would you appoint as a leader, or who would you suggest that would become a leader for such initiative, or who should advocate for such a program? I mean, it depends. We cannot argue that one person over here on this list is more important than the other. However, you would need, again, to pick someone who's a fierce advocate, someone with clinical familiarity with anticoagulation, someone with expertise, and maybe someone with great interest. I would pick out of this list people from the pharmacy, people who would have like in-depth knowledge of anticoagulation aspects and its reversal, people who will be able to put together policies and procedures and work with different disciplines of the hospital and different specialties in order to put together a great program. A physician should probably be one of the people who should help kick off this program as well. So those will be key people that you would want to have them sitting around the table to pitch this to at a higher level. Moving forward, you would need to ensure that you have some sort of a mechanism to get the continuous feedback from all these disciplines touching the anticoagulation at some point. You probably don't want them to come and sit with you in each and every meeting, because it's really hard to put together about 20 people in one room and have them all commit to one meeting. However, you would want to ensure that those disciplines are at least reaching out throughout their practice and ensuring that they solicit the great information that's out there, bringing it back to the table, representing their teams, and help you advance the practice and the initiative moving forward. A keystone to the success is to perform data collection, tracking, and analyses. And this is actually, I would call it the one most important part of establishing a great program. This is something that's going to go a long way towards the sustainability and the resumption and the adoption of a great program. You would need at the beginning to have some baseline data on what is the current performance of the organization or the practice where you're at, and talk about what can you do better, and how would these initiatives that you would want to implement and why such an anticoagulation stewardship program would be beneficial to your patients. You could argue the cost, you could argue the length of stay, you can argue the readmission rate. You could start out with some sort of a compelling story of a patient who probably that was readmitted with a pulmonary embolism just because they have failed to continue or to address the needs for their anticoagulation at the transition, at a one transition of care. So this is very important. Some of the key elements probably high priority would be to highlight the under or the overutilization. I'm sorry, let me just go back. Or you could also highlight an inappropriate laboratory or diagnostics, suboptimal management of adverse drug events, or suboptimal care transitions, or excessive event rates such as bleeding or thrombosis. If you will be able to pitch that to the listening ears at an administrative level, you can really have a buy-in to the initiative and a success towards the early implementation or the rapid implementation of a robust program. Examples of possible metrics that you could ask about, I mean, this could be inpatient-centric, or could be things that you can incorporate at an ambulatory care setting. Things like percentage of care transitions with appropriate documentation, proportion of patients receiving formal education, incidence of anticoagulated related adverse drug events, or adherence rate to management protocol. You would, after putting all these pieces together, and if you have a buy-in within your organization or within your practice, into such a program, you need to implement all these elements and put it together to ensure that everything is working systematically or at a systematic level. Implementing these sustainable and efficient evidence-based actions at the system level, and assure the safety and the quality of the anticoagulated management. If you have the policies and procedures put in place, if everything is standardized, if you utilize your electronic health records and your decision support features in order to put together high quality anticoagulation stewardship program, utilize those advanced educational programs and many more activities that would probably not be mentioned here. If you put all these together on a systematic level, you will be starting off and paving your way to success early on. So as we will move through the slides, I'm going to share with you some of the things that we implemented over here at a systematic level at Cleveland Clinic Abu Dhabi that are not necessarily called anticoagulation stewardship activities. However, these are things that were implemented throughout the system level that if we would push and advocate for, or even pitch or ask or petition for an anticoagulation stewardship program, we would likely be very successful and have a buy-in from our administrative team. Facilitating the transition of care, one of the maybe one of the most important core elements of a great program. And one over here, one could think over here that the transition of care is only at the time of discharge. However, this is actually throughout within the same organization or within a system level. So you could be transitioning from an ICU setting into an acute care setting. You could be coming from an outpatient setting and being readmitted as well. Or you could be residing in a long-term care facility and receive anticoagulation management or therapy at the transition of care. This is the time where most of the patients are highly vulnerable to errors, and it is a key to ensure that we have all the information and all the documentation and all the elements of success in place to ensure that whoever is going to inherit that patient moving on have enough communication and tools in order to sustain and continue the treatment with the anticoagulation medications in a safe and healthy manner. So as we said, this could be inbound or outbound patients. This also could encompass patients who are undergoing elective and emergent procedures. As we mentioned earlier, patients could have their anticoagulation drugs interrupted prior to a particular procedure. So if you don't know or have an in-depth knowledge, well-trained staff about the benefits and the pharmacodynamics of these drugs and when should you stop them, how should you reverse them, should you have an emergent procedure coming on, or when you should resume them after that elective procedure. This is something that is a key that you would need to have policies and procedures and everything outlined so that you are not at a loss when handling such patient population. Last core element, and as important, is to advance the education, comprehension, and competency. You would need to ensure that all your clinicians are well trained and they are continuously being assessed for competency. You would need to make sure that your patients also are well informed, well trained, and well educated about the anticoagulation management, why they're taking it, what's the dose that they're taking, how to manage their adverse drug events, and the duration for which they're going to take their anticoagulation drug. anything that they could experience, any drug-drug interactions, or anything that pertains to the anticoagulation management that they would need to report, how to report it, and how can they talk to you, and how you would be able to follow up with them. So now you could ask yourself, and I will ask myself this question as well: where do you stand today as a practice and as an organization? And do you have a great or the recipe for a successful, or what meant to be a successful, anticoagulation stewardship program? The Anticoagulation Forum had actually put together a great checklist over here for the core elements. You could actually start out by addressing the high priority needs for the organization, or the high priority needs that you have captured that will align with the needs of the immediate needs of the organization, and justify it by talking about the readmission, length of stay, cost saving initiatives throughout the patient stay. So the core elements, the Anticoagulation Forum, had put together this administrative oversight gap analyses, a series of questions that you can go through and score yourself as an organization, and come up with a score that will address the high priority needs. These are just some of the examples of the high priority goals that are identified in a hospital setting. For example, VTE prophylaxis, quality improvement measures, safety, peri-procedural management, reversal, and care transitions. All these that we have discussed early on when we address the core elements will be considered high priority goals that you would need to address at an early stage when you implement such a program. Now, for those programs or those organizations who are seeking or who want to become a center of excellence, if you know that you have a robust anticoagulation stewardship program, or if you have all the key elements, or if you scored high upon performing that gap analysis and you want to become a center of excellence, again, the Anticoagulation Forum had put together a series of questions that you can go through. These series of questions will first take you through and ask you about what kind of a practice setting you are, how many patients do you see, and the type of patients that you see, and whether or not you have trained physicians that will be able to address such needs for anticoagulation management. Moving on, these will be questions that will address the drug therapy management. I'm just going to mention over here, if you have anticoagulation therapy discontinuation policy, or maintenance policy, or initiation policy, you can also check the boxes over here and proceed into the disease state management. Do you have the tools to address such needs? The transition of care coordination, a series of questions that will highlight a lot of the issues that we spoke about earlier. If you have policies in place, if you will be able to facilitate the discharge, if you will be able to address the needs of the patients prior to discharge, during discharge, and beyond the discharge, and throughout the different settings of care. And if you have any service operational performance measure, the keystone is to look where you were standing at baseline, show progress and improvement in order to maintain and sustain such a program, and justify its need and value. As you go through the series of questions over here and go through all the elements, you would come up to a final score, and this will tell you whether or not you will be considered a center of excellence. And if you're not, it will highlight the high priority goals that you would need to address, things that will be of an immediate, that will require your immediate attention and would be of a big magnitude upon implementation, that will boost your score and put you at a higher level towards achieving the excellence status. some colleagues over here listening would ask the question towards the end, so I'm just going to jump in and probably highlight some of the key resources that you could refer back to. The Anticoagulation Forum actually hosts a couple of boot camps every year, one in March and one in September of every year, I believe. These are live boot camp sessions that you could attend over two or 3 days that would be highly beneficial. This year, these had been put on hold due to the pandemic, but with the availability of our of Zoom and these resources, you would be able to participate and enroll. This is a good start for those who are seeking some in-depth knowledge and some sort of a networking to stay up to date with whatever is happening on the anticoagulation stewardship world. Another great resources would be if you are seeking special training in anticoagulation, the University of Southern Indiana and the University of Florida have great programs that you can actually enroll and attend and obtain a certification. For those individuals listening right now and practicing in the US, there is the certification in anticoagulation management, the CACP, that's offered through the board. If you're only practicing in the US and you have to meet specific requirements, you should be able to become certified. I'll be happy to share with you more information on that and push it out to you should you have any further questions about it. Now, as to what we have over here at Cleveland Clinic, let me talk about how we have incorporated what we know from our policies and procedures and from the guidelines into our order sets or into our electronic health records in order to optimize patient care and ensure safety and quality of anticoagulation management throughout the hospital. This is an example for an order of rivaroxaban that had been placed by one of the physicians who is wanting to prescribe rivaroxaban for a patient who had just been admitted with a DVT or with a DVT. So we have a panel over here that he can select from. So there is a DVT PE initiation treatment. So the dose for that would be definitely different than the DVT prophylaxis, or the continuation different than the dose for the non-valvular AFib or the ACS dose as well. So this is an example that speaks to how you can use the tools within your electronic healthcare records to optimize prescribing. This is an example on dabigatran and the dose adjustments that are warranted for patients with impaired renal functions. And this breaks it down. You would only have to check a box. This is highlighting the need to address the creatinine clearance and changing the dose accordingly. As we can see on the third part, if patients are receiving any concomitant therapy with dronedarone or ketoconazole, the dose reduction will be warranted. So this is also addressing drug-drug interactions. So again, the system over here, you are utilizing the system to protect you and incorporating all these alerts and guardrails that will ensure the safety and efficacy of the anticoagulation management. This is an example of a heparin weight-based dosing protocol that's also incorporated as an order set. This is a pathway that the physician would just have to enter if a physician is ordering heparin infusion for a patient with a DVT or acute coronary syndrome, stroke, a patient on a VV ECMO, or a patient with a new bioprosthetic mitral tricuspid valve. The doses upon initiation and continuation are different, and the monitoring parameters over here are incorporated and embedded within the order set This will guide the physician to place the right order and will guide the nurse that cares for the patient at the other end to follow a particular pathway into drawing the PTT at a particular time, adjusting the doses based on a calculator that's also incorporated within the medication administration record for the patient. This is also another great example of having policies and procedures in place. The acute coronary syndrome protocol, this will highlight and address all the issues that are related to heparin dosing in that patient population. So we have a policy for that is published and is readily accessible on the organization's SharePoint. We have an antithrombotic reversal procedure as well. This is also addressing things that are related to reversal agents should questions arise. This is also an example into incorporating a reversal agent into, or a high cost drug as well, into the management or the order sets. You will not be able to order a PCC without going through some of like a checklist, and these parameters over here that are set and they are extrapolated from the guidelines and the dosing recommendations will guide you to order the right drug for the right indication at the right dose and monitor the patient accordingly, the way it states throughout the protocol. Not only that, this should be addressed at an prescribing and transcription level, but this is also on a preparation level. So this is from a pharmacy part. This is how the order appears for the pharmacist at the other end. So a pharmacist could receive an order for a high cost drug, either suzimab over here to reverse dabigatran toxicity or dabigatran, and throughout the protocol, this will guide the pharmacist into the processes on how to process the order, what to check for, how to prepare the order, how to reconstitute it, and how to administer the drug, and how to document and monitor the patient's progress thereafter. Now comes the monitoring dashboard. This is a dashboard that's built into each patient's record on an anticoagulant that's going to address any parameter that would be affected by the administration of any anticoagulant. As we can see, you can see the PT, INR, anti-factor, anti-10A level, hemoglobin, hematocrit, D-dimer, fibrinogen level, and whatever parameters that are addressed over here are actually incorporated in a time frame upon the time a particular dose of warfarin or heparin or a reversal agent had been given, so that you can actually assess the effect or the direct effect of a particular agent on lab parameters as patients will progress with their care. I hope that I have given you enough information on some of the core elements and some of the strategies. Again, I would like to highlight over here that we had not necessarily had implemented the anticoagulation stewardship related activities in full, but at least we have a lot of the key elements that will help us push for this. So I am in your shoes today. I am advocating for something that you probably had either advocated for or you have a great passion to advocate for. I thank you for this opportunity today. And with that, I conclude my presentation and I will be ready to take some questions. Thank you.
Thank you so much, Dr. Ismail. It was really an interesting and informative presentation, I must say. Now, Dr. Ismail, we have some questions that were sent to us during the presentation.
Okay.
And so the first question is, in order to initiate anticoagulation stewardship in a hospital with little or no technological resources, what should be the first step towards initiating the program?
That's a great question. And this is a challenging question, but this speaks volume about the passion of people who are wanting to establish something. So I would say it is very time consuming and highly cumbersome to start such a robust program within an organization that do not have electronic health records in place. The how to extract information and look through paperwork and document properly will be all subject to variation, and you could probably overlook some information or either report something that it's done without happening or miss something that had happened that will lead to probably some optimal outcomes as you try to implement the program. So what I would say at the beginning is I would start in such a setting with lack of electronic health records. I would start with advocating for this and put together policies and procedures, and try to set guidelines and educate the staff. So you would definitely have to spend more time educating the staff and the patients on the value of and the need for anticoagulation management, the risk and the adverse events. Everything that you will take at that level will pay back. However, you would just need to do that on a continuous level and ensure that you have the boots on the ground to tackle that on a sustainable level. With time, as you incorporate electronic health records, people will be actually more familiar, and you're way ahead than others when you try to educate staff. So you could skip that part then, and then work through your experiences on establishing things through the electronic health records. People had learned from scratch, and then you would be able to move forward. So my answer is throughout education and putting together policies and procedures.
Okay, thank you so much. So the next question is how suboptimal care transitions occur in case of anticoagulants?
I'm sorry, how suboptimal?
Care transitions occur in case of anticoagulants.
So I'm just going to speak out of what I have experienced. So what you could experience is someone who is being discharged or who will be discharged on an anticoagulant that will have, for example, their needs not being addressed around the discharge. Let's say a patient who was on a parenteral anticoagulant throughout their stay in the hospital. This was stopped, and they were supposed to continue a particular regimen for, let's say, another 3 months. And this was missed around the discharge. The pharmacist or the physician that was going through the after visit summary had skipped that we are switching from a parenteral to oral. So a patient could leave the hospital thinking that they have gotten the treatment for their DVT that they were admitted for, and go home without an oral anticoagulant. So that could happen. Another suboptimal anticoagulation management would be if you are trying to push and discharge the patient on an anticoagulant drug that you know that the patient will not be actually compliant with. So if you have an elderly lady who is 85 years old that you want her specifically to be on warfarin, knowing that she's frail, she's not going to eat well, and she's not going to be able to come to that clinic every couple of weeks to check her INR. If you insist, unless you have a specific indication that warfarin would be the only drug for her, you should try to look for options for her and try to optimize the therapy that will serve her needs as a patient, will serve her familiarity, and make her something that will ensure that she will be at least more compliant with the therapy. A lot of times we see patients leaving the hospital and not coming back to check their INR just because they're living away from the hospital, or just because they cannot leave their work, or if they have even sometimes language barriers. So that is a suboptimal management. So you need to have all the pieces of the puzzle together. You need to put together the patient needs, the indication, the cost itself. You could discharge a patient on a medication that you know that they will not be able to afford, or that their insurance is not going to cover. I think that is a recipe for failure, and that is suboptimal management at the care transition.
So the next question is, do we need some special certification for a pharmacist running this stewardship program?
Great question. As I said earlier, you would probably not need specific certification to advocate for this. I recall yesterday that I was working with one of my favorite residents, and within 1 hour, we received 7 or 8 phone calls, half of which were to address the anticoagulation managements for the patients who were in the inpatient. And one of them was for a patient who's being discharged. So this is something that comes very often, and you will experience very often. A pharmacist with decent experience and broad knowledge of anticoagulation aspects could probably lead this initiative and actually advocate for it. You just need to sustain, read, and maintain, and always look into advancing your knowledge, and follow up whatever comes back, or whatever comes in the guidelines, or whatever is being updated in the guidelines. Certification will give you in-depth knowledge and the opportunity to network and further advocate for things that you can implement past the patient education and policies and procedure level. You could actually advocate, you can participate in clinical trials. So certification and working through an entity would be beneficial. As I mentioned, the CACP, or the Certified Anticoag Care Provider, is unique to those who are practicing in the US, because it would require US license and practice in the US. However, the boot camp that is offered through the Anticoagulation Forum will be something that I would start with and I would follow if I want something to start with.
Okay. So the next question is, what hurdles can be encountered in implementing this program?
The hurdles can be encountered throughout the implementation and throughout the time that the program is being sustained. So the biggest hurdles would be to have a buy-in to the value of the Anticoagulation Stewardship program. And as we mentioned before, if you have a fierce advocate, if you have someone who can talk the talk and let you after that walk the walk and take you through the success, somebody who have a great sphere of influence within the organization, that would be a key element. If you walk into with a very weak proposal without a justified value, without any data, I would say that you will be turned down. In my opinion, if you have no data, then you are just a person with an opinion. If you walk into an office of an administrator and say, I want an anticoagulation stewardship program just because I like it, you will be turned down. If you back this up with a great proposal and pitch it into the right ears, you will have a buy-in. That would be the key to the adoption of the program. Now, in order to sustain the program, the metrics, if they are in place, if you have the policies and procedures, and if you sustain the education and ensure competencies across the system, you will definitely come out very successful towards the end.
Okay. So the next question is, what are the key performance indicators for this program?
Key performance indicators would be probably very broad to discuss. There is a nice article that is actually shared through the Joint Commission that I would be pushing out probably and share the link towards the end of the presentation through Dr. Rima, and I'll have her share it with the group towards the end. there are some key performance indicators that you want to start with. You don't want to start big, and you want to tailor those key performance indicators to your organization needs. If you are working at an ambulatory care setting, you could be talking about adherence. You could be talking about adverse drug events, or you could talk about insurance plans, or you could talk about barriers to compliance and adherence. If you are inpatient centric, you could be talking about dosing adjustments, and you can talk about dosing initiation, appropriateness of time lapses, and so on. So this is an endless key performance indicators that you can share. However, as we mentioned earlier, you need to start with the low-hanging fruits, the things that will have an immediate impact, things of a great magnitude on the cost saving and direct patient care that you will be able to easily justify to your hospital administration to proceed. I will be pushing out the link throughout the end of the presentation to Dr. Rima so that she can share with the members of the group shortly, inshallah.
Okay. Dr. Ismail, there are two more questions left. Kindly explain the protocol of administration anticoagulant at COVID-19 patients who are admitted at ICU.
Okay, so we have put together actually a system-wide policy to address not only the needs to address anticoagulation management for patients in the ICU, but throughout the whole system. I will gladly share that also to Dr. Rima towards the end. Just for the lack of time, this might be a little bit broad to discuss over here within this setting, but I will be pushing this out throughout the network towards the end of the presentation, inshallah.
Okay. And here's the last question. If a patient on warfarin experiences some bleeding issues on subtherapeutic INR, will we report this as an adverse drug event due to warfarin?
If you have a subtherapeutic INR?
Yes.
And you are bleeding?
And a patient is coming at ER with a bleeding issue.
Okay.
Shall we report it as an adverse drug reaction to a warfarin or not at subtherapeutic INR?
That's a good question. I mean, patients could bleed unless you know that the patient is bleeding directly from like a particular wound or a particular abscess that they have, or if they have a hemorrhoid, or if they have something in particular that is causing the bleeding, you would probably not associate that with warfarin necessarily, unless the INR was elevated. However, it might have been bleeding that had happened prior to the patient coming to the hospital. So if we have somebody with a GI bleed, GI bleed happens silently, and you probably sometimes would not be able to catch it earlier. And the patient came in with a subtherapeutic INR because they have not taken the warfarin for a couple of days, and they are admitted with GI bleed. Yes, I mean, if only the warfarin was the drug to be associated with bleeding for that patient, I would report that as an adverse drug event, or at least highlight it and possibly think about warfarin being one of the causes. Yes.
Thank you so much, Dr. Ismail, for answering these questions and for the great presentation. It was a pleasure having you with us. So this concludes our today's session. Thank you all for attending. We hope you have learned a lot from this session. Allah Hafiz.
Thank you so much.